Welcome everyone. Again, this is session 165. My name is Jody Novotny. I'm a volunteer with ThyCa. I'm really happy to be here today. The title of the session is Navigating Health Insurance, trying to figure out how to pick a health insurance plan that actually covers your medical expenses. I am very pleased to introduce our speaker, Monica Bryant. Monica is a cancer rights attorney at Triage Cancer Center in Chicago, Illinois. She is the Chief Operating Officer for Triage Cancer, which is a national nonprofit organization that provides education and resources on cancer survivorship issues. And so with that, I will turn it over to Monica.
Thank you so much, Jody. I really appreciate that introduction, and I appreciate all of you for joining in. I know we have people from all over the place, so for some of you, it might be a little bit late, but we're going to spend the next hour talking about navigating health insurance and how people can make choices between their various options to make sure they are maximizing coverage and limiting out-of-pocket expenses. As Jody mentioned, I did co-found a nonprofit called Triage Cancer, and our mission is to provide education around the practical and legal issues that can arise after a serious diagnosis like cancer. And as you can see, those practical and legal issues really run the gamut, from health insurance to employment rights, to estate planning, to disability insurance, to finances, and everything in between. So because we only have an hour together today, we're really going to be pretty high level, and we're only going to touch on some of these topics. And I'm going to point you to places where you can get more information. Triage Cancer provides education in several different ways. So we host our own educational events focused on these particular topics that are free for anybody to attend. We also have a number of online resources and worksheets and quick guides, which are 1 to 4 page documents that are a snapshot of a particular topic. We also know that people learn in different ways, and so we present some of this information as animated videos that are available in different languages. So I just want to bring this up at the start of it, because if you hear me say we have more information on this and I point you to a place, I just want you to know that it's all available at triagecancer.org, and it's all available for free. So today doesn't have to be the only opportunity for you to learn. So one of the things that we hear on a regular basis from people is that with the cancer diagnosis comes an extreme financial burden. And that financial stress or financial burden has a name. In 2013, researchers out of Duke coined the term financial toxicity to really describe that burden that can happen after a diagnosis. We have been talking about financial toxicity for decades now, and one of the reasons that it's so challenging to address financial toxicity is that there are multiple contributing factors. And the number one most significant factor is health insurance. Now, for some people, it could mean not having health insurance at all, but more often it's about someone not having the right policy for their needs or not navigating the policy effectively. Of course, the employment changes that can occur after a cancer diagnosis can impact somebody's finances. And then all of the things that normally happen in life that will impact our finances, like relationship changes or moving or graduating, those things continue to happen even after a cancer diagnosis, just compounding the issue. So we are going to spend today talking about that number one contributing factor, which is health insurance. One of the challenges around this health insurance piece, which realistically should be pretty easy for us to solve, is that it's like learning a new language, but very few people are ever taught that language. And we've known this anecdotally for years, that it's confusing and people don't really understand the way that health insurance works. And now we have all sorts of data and studies that actually show this. So this particular study showed us that only 4% of Americans could actually define the 4 most commonly used words in health insurance. So if people don't even understand the words that are being used, how can we possibly expect them to be informed and educated consumers and pick the right policy for them? So with that, I'm going to start at the basics. And I appreciate that some of you, this might be old hat, but I also just want to make sure that we are all on the same page before we get into the more complicated pieces. So with respect to the terms around costs, there are costs just to have health insurance, and that's going to be your monthly premium. You're going to pay that amount each month, whether you go to the doctor or not. So it's like having car insurance and never getting into an accident and filing a claim just to have the insurance. But then there are some additional costs that you will incur when you actually go and use your healthcare. These are going to depend on policy. And the first is your annual deductible, which is a fixed dollar amount that you have to pay each year before your health insurance starts picking up their share of the costs. So you could have a policy with a $500 deductible, you could have one with a $5,000 deductible, but it is always going to be that fixed dollar amount that you have to pay before the insurance company starts chipping in. So what's their share of the cost? Well, that's referred to as cost share or co-insurance, because you're literally sharing the costs. This is going to be a percentage. So for example, it could be that you have an 80-20 plan. And that means that once you've paid your deductible, the insurance company pays 80% of your healthcare costs and you're responsible for 20%. Then many policies have an additional payment called a co-payment. And this again is a fixed dollar amount that will depend on the policy. It could also depend on the service that you're getting. So for example, you could have a policy with a $25 copayment to see the doctor, or a $35 copayment to go and see a specialist, or a $250 copayment to go to the ER. But perhaps the most important thing for you to understand about your health insurance policy is the out-of-pocket maximum. Because the out-of-pocket maximum represents the most that you're going to pay out of pocket for your healthcare per year. So it's always going to be presented as a fixed dollar amount. And the way that you get to your out-of-pocket maximum is by adding up everything you pay towards your deductible, everything you pay towards your co-payments, and everything you pay towards your co-insurance. So it's everything you're paying out of pocket except those monthly premiums. Now, the devil's in the details here. Typically, insurance companies will only count payments made towards in-network providers towards that out-of-pocket maximum. And some employers might have a slightly different math problem involved here. So for example, they might exclude the deductible, for example. But generally speaking, this is the math problem. And if you have an employer plan, you should check your specific plan to see how they calculate that out-of-pocket maximum. So here's an example of how all of this works. Meet Dan. Dan has a plan with a $2,000 deductible. It's an 80-20 coinsurance, and it has an $8,000 out-of-pocket maximum. Dan hasn't used any healthcare for the year yet, but he gets into an accident and ends up with a $102,000 hospital bill. So what does Dan have to pay? Well, the first thing that we pay is that deductible. We subtract it from the overall bill, leaving $100,000 left. He has an 80-20 plan, which means that his plan will pick up 80% and he's responsible for 20%. 20% of $100,000 is $20,000. But does Dan have to pay that full $20,000? The answer is no. And the reason it's no is because he has that $8,000 out-of-pocket maximum. So because he's already paid $2,000 towards his deductible, he only has to pay another $6,000 to get to his $8,000 out-of-pocket maximum. So I am not suggesting that this isn't a lot of money. Of course it is. But when we start looking at the alternatives, $8,000 starts to feel a little bit more reasonable. So there is a question about showing the next slide. And for the sake of time, I am going to keep going. But know that if you would like to hear any of that again, the terms that I just explained or this example, that's what's included in our animated video on health insurance basics. It's also included in our quick guide to health insurance. So there's plenty of places to see that again. So I hope you'll take that for this time. Now, in the United States, there are two main payment systems. Fee for service, which is where you can go to any provider that you want and the services are unbundled and you basically just pay for the service. The other type of payment system is called managed care. And this is where the services are bundled under an umbrella of a particular plan. And there's going to be a network of providers that have agreed to participate in that plan's network and agreed to accept a certain amount of money for participating in that particular plan. So an example of fee for service is original Medicare, where you can go to any provider around the country that accepts Medicare and receive services. And an example of managed care is Medicare Advantage plans. Many employer plans are also managed care plans. Now, within managed care, there are lots of different options. And these are three of the most common that we see. So starting on the left with the Health Maintenance Organization, or HMO. These are going to have the smallest networks of providers. And typically, you're going to have to start all your care with the primary care physician. If that primary care physician can't solve your medical issue, then they will refer you out to a specialist. So in exchange for less choice among providers and more hoops to jump through in terms of accessing care, you're going to pay less. Now, all the way over on the right is preferred provider organizations. And these are going to have the largest network of providers, many times across different hospital systems. You do not have to start with a primary care physician, and most PPOs have some out-of-network coverage. So you want to see someone out of the network, great. They're going to cover it, but they're only going to cover it at, let's just say, 50% instead of at their normal 90%. So in exchange for all this flexibility and choice, you're going to pay the most with PPOs. And then EPOs, or exclusive provider organizations, are sort of in between these two, where it's a hybrid of the two. And so this is typically when we're in person where someone raises their hand and they say, well, which is better? And my answer is always, it depends. So it depends on what that person's needs are. If they're someone who rarely goes to the doctor except for sort of an annual checkup, then maybe an HMO is the best option. Conversely, typically if they're sitting in a room listening to me talk, they have some sort of serious medical condition, which means they're seeing doctors all the time, potentially specialists across those different hospital systems. Maybe a PPO might be the better option for them. But the point of talking about this is that there is rarely a one-size-fits-all answer to what's best. So in this country, there are 3 places where we get our health insurance. The largest number of Americans get their health insurance through an employer. The next largest group get their health insurance through the government, primarily through Medicare and Medicaid. And the smallest number of Americans go directly to a health insurance to purchase their health insurance. So there is going to be a poll launched today, and I'm going to ask for you to just take a few seconds and let me know where you anticipate getting your health insurance coverage for the next year. So poll on your screen. Fantastic. Well, thank you all so much for answering that. That's really helpful for me so that I know where to sort of spend my time talking. So I appreciate that. So given that over half of you are anticipating getting their insurance through an employer, it begs the question, what happens if you have to stop working for some reason? What are you going to do for health insurance? One option is to elect COBRA. COBRA is the federal law that allows eligible employees and dependents to keep the exact same health insurance policy when they would normally lose it. Exact same policy, same providers, same networks, everything you've paid into the deductible and the out-of-pocket maximum, exact same thing. Except now you're going to be responsible for 100% of those monthly premiums plus a 2% administrative fee. So it can feel very expensive to pay for COBRA monthly. Pros and cons to it. In order to be eligible for COBRA coverage, you have to work for an employer with 20 or more employees. So what happens if you work for a smaller employer? Well, then I would suggest that you look to see if your state has a state COBRA law. They definitely vary state to state with respect to the details, but this sort of gives you a big picture view of which states have state COBRA laws. And you can find more information on triagecancer.org under our charts of state laws for health insurance. Because if you work for an employer with under 19 or under employees, you're going to be looking at your state COBRA law, not the federal. Now, a lot of times when I bring up COBRA, people will say to me, it's just too expensive, there's no way, or that can't possibly be my best option. And while I recognize it definitely can be expensive to elect COBRA, there are still some benefits and there's still some validity in keeping it as part of the analysis or the sort of thought process when you are potentially losing your employer-sponsored insurance. One, the coverage could be better. It could be about the network. So sure, you could find a cheaper plan, but maybe your doctors aren't in that plan's network. But it could also still be the less expensive option. Recently was talking with a gentleman who was trying to figure out his options for the last 3 months of the year, but he had already met his out-of-pocket maximum. So I was trying to explain to him that it's actually cheaper for him to elect COBRA and know that all he's going to be paying for the rest of the month or rest of the year, are those monthly premiums. Whereas if he picks up a new plan, he's starting everything over at zero again. But I do recognize there are still some significant challenges with COBRA. Now, for individuals who are over the age of 65, can you tell it's Friday evening? For individuals who are over the age of 65 or have been receiving Social Security disability insurance for 2 or more years, or have end-stage renal disease or ALS, they may be eligible for Medicare. Medicare is a federal health insurance program for these individuals. Medicare is incredibly confusing. And one of the reasons that Medicare is incredibly confusing is that it's actually not one thing. There are 4 different parts to Medicare, and each of the different parts covers a different aspect of your healthcare and has different costs associated with it. So I'm going to give you the 50,000-foot view of it, and then I'm going to point you to all the places where you can get more detailed information about Medicare. If you are either already in Medicare or eventually you will be in Medicare, you basically need to pick a lane to drive in. And here's what I mean by that. Lane 1 is what we call original Medicare. And it's where you have Part A to cover your hospital insurance. So it's when you're inpatient. Then you're going to pick up Part B, which is your medical insurance. And so that's going to cover things like doctor's visits and immunizations and screenings and lab tests and IV chemotherapy. If you worked and paid into the system, Part A will be premium free, but there's still a monthly premium for Part B and an annual deductible of $203 for this year. And Part B comes with an 80/20 coinsurance, which means once you've paid your $203 deductible, you're responsible for 20% of your healthcare costs moving forward. The reason we call this original Medicare is because when Medicare was first signed into law, this is all that existed. Many, many, many years later, in 2006, Part D was signed, and Part D provides prescription drug coverage. Part D plans are sold by private insurance companies, so the costs for Part D plans are going to vary pretty widely. Now, remember how I said there's that 20% coinsurance with Part B? There's no out-of-pocket maximum. So you pay that 20% all year long. So how do you protect yourself against that out-of-pocket costs? You can pick up an additional insurance policy called a Medigap plan. And these are sometimes called supplemental plans. I think one of the reasons why Medicare gets even more confusing is we have multiple names for the same thing. But these Medigap plans are, again, a separate insurance policy that you purchase from a private insurance company, and they're identified by letters A through N in most states. So sometimes people will say to me, I have Medicare Part G, and we have to explain to them, you probably don't. What you probably have is a Medigap Plan G. So there's just so many layers of confusion here. But what's important to understand about Medigap plans is that they cover, or some of them, depending on which letter you pick, but let's say you pick a G or a C or an F, they're going to cover that 20% that you're paying out of pocket in Part B. So those Medigap plans are the way to protect yourself from a unlimited out-of-pocket costs. That's lane one. Lane two is Part C, otherwise known as Medicare Advantage. Turns out, potentially having 3 different premiums and deductibles and cost shares in lane one is a lot. And so an alternative is found in lane two. Part C plans are managed care plans that have a small network of providers that you can go and see. And Advantage plans will bundle all of the services that you would get under Part A and Part B. About 90% of all Advantage plans also include prescription drug coverage, but if you pick one that doesn't, you can pick up a standalone Part D plan. And that's where your options end in lane two. And the reason for that is that Advantage plans come with an out-of-pocket maximum. So again, this is where we get that question of like, well, which is better? Again, I say it depends. There are definitely pros and cons to driving in both of these lanes. But what I do want to make sure we talk about is all the places that you can get more information about Medicare, including our brand new animated video series on Medicare. So if you just are starting from square one and you really have no idea what your Medicare options are, I highly recommend spending the 20 minutes to watch all 4 of these to sort of get your legs under you. Now, if you do have, you're not at square one, but you still have questions, we have a 90-minute webinar that I just recorded a few weeks ago. So it's current to this year that you can watch for free on our website, as well as tons of quick guides. And we hope to be releasing a few more requested items in the next couple of weeks as well. And of course, I'm happy to answer Medicare questions here today as well. Now, I'm briefly going to talk about the other government health insurance program in case it's relevant to anybody didn't want to share, or other people in your communities. Medicaid is a government health insurance program that has changed over the years. Prior to 2014, in order to access Medicaid, you had to have a low income level and a low resource level, which are things like life insurance policies or savings accounts or retirement accounts. And you had to be able to walk through one of these 4 doors. Typically in the cancer community, people were walking through this door on the left, through the Age Blind Disabled program. There were multiple challenges with this, particularly that people basically had to spend down everything in order to access the program. And this was the highest standard of disability that exists in the law. So it was very challenging for people to access the Medicaid program with this. The Patient Protection and Affordable Care Act, otherwise known as the ACA or Obamacare, was passed in 2010, and it created a fifth door starting in 2014. And this fifth door is just based on income. So for people with incomes at or below 138% of the federal poverty level, they could walk into the Medicaid program through this door. They didn't have to prove that high level of disability, and they didn't have to spend down all of their assets. And this was particularly useful for people in the cancer community who maybe are now in a different situation due to their cancer diagnosis, but maybe have some savings or a life insurance policy. So the original four doors still exist with that income and resource test. That is the same. It's just that we added a fifth door. And this fifth door was supposed to exist in all 50 states. The Supreme Court got their hands on the Affordable Care Act and muddied the waters a bit and essentially made it voluntary for states to expand their Medicaid program. And this is where we are right now. 38 states in DC on the left have expanded their programs, 12 on the right have not expanded their programs. And the states on the right represent about 3 to 5 million people who would have access to healthcare if their state had expanded. So I bring this up because this is still a significant public policy issue. Sometimes people will ask us, well, I'm not on Medicaid, why do I care if my state's expanded? And I can appreciate the question, but there are actually now, we have many years of data to show us that things improved for everybody in the states that did expand Medicaid. Premiums for everybody have gone down in these states. Hospitals have been able to stay open. People have been able to access care. So there's lots of different arguments for why it's beneficial for all of us for states to expand their Medicaid program. Now, the ACA, in addition to creating that new door, also created a new way for people to purchase health insurance. And they did that through the state health insurance marketplaces. When the law was originally passed, they were called exchanges, but no one really knew what that was. So they renamed them marketplaces. Turns out no one really understands these either. The best way to talk about marketplaces is to compare them to a health insurance shopping mall or Amazon for health insurance. What you are purchasing when you go to the marketplaces is private insurance from private health insurance companies. So in our triangle of coverage over here, these marketplace plans actually fall at the top. They're not government insurance. It's just that the government built the mall, so to speak. So I often get questions, well, okay, if it's private insurance from a private insurance company, why do I need to go through the marketplace? Why couldn't I just go straight to the insurance company? Again, a fair question. The answer is there are some added benefits to purchasing through the marketplace. So there's quality control. In order to sell in the marketplace, plans have to meet minimum standards. So you know that what you're purchasing is comprehensive coverage. There's also caps on the out-of-pocket maximums for plans sold in the marketplace. So for this year, the cap is $8,550. There's also financial assistance for people to purchase plans sold in the marketplace. And there's two types of financial assistance. The first is a premium tax credit, which will reduce the amount someone has to pay per month just to buy the health insurance. Then the second type is a cost sharing subsidy, also known as a reduction. These are going to reduce things like your deductible or your copayments. Now, the financial assistance is based on household size and income level. So in states that expanded Medicaid, those states on the left, if you have an income at or below 138% of the federal poverty level, you'll have access to Medicaid. If you have incomes between 138 and 400% of the federal poverty level, you'll have access to a premium tax credit. If you have an income between 138 and 250%, in addition to getting a premium tax credit, you may also be eligible for that cost sharing subsidy. It looks a little different in states that didn't expand Medicaid because that's no longer an option. Now, the premium tax credit amounts stay the same, so from 138 to 400%. but the cost sharing subsidies go down to 100%. The problem with this fix, so to speak, is that it's the premium tax credit that helps me purchase a plan. The cost sharing subsidies are only useful once I have a plan. And so this sort of attempt at fixing the gap that the Supreme Court caused doesn't actually help a lot of people and inadvertently cause an additional disparity, because now we have a situation where someone who's making $50,000 a year gets help buying their health insurance, but someone who's making $15,000 a year gets no help. So that's a significant problem in those states. Now, I do want to share with you some late breaking news. So there's been legislation passed as a result of COVID that added some additional financial assistance to the marketplace. And anyone can benefit from this financial assistance, even if they haven't been impacted by COVID. So for people with incomes at 150% of the federal poverty level, they'll be eligible for a marketplace plan for $10 a month or less. And they've actually also increased the ability for someone to get financial assistance if they make over that 400% of the federal poverty level, and their monthly premiums are more than 8.5%. So if somebody's paying more than 8.5% of their household income every month in premiums, even if they're over 400% of the federal poverty level, they can still get some assistance. I wanted to make sure to talk about this today because, you know, we hear from a lot of people like, oh, I don't want to look at the marketplace. I looked last year and it was just still too expensive. That certainly could be true, but the point is, this is a whole new year and there are new options. So even if you've looked in the past, it is potentially worth spending the time to look again just to see what your options are for next year. Now, there are times of year when we get to make changes to our health insurance or enroll in new coverage. So Medicaid applications are accepted year-round. As soon as somebody becomes eligible, they can apply. Employer plans vary from employer to employer, but many times employers will use a fall open enrollment to start then their plan January 1st. Medicare open enrollment is every year from October 15th to December 7th. So we are in Medicare open enrollment right now. And Marketplace open enrollment will start November 1st and go through January 15th of next year. Medicare plans and Marketplace plans are calendar year plans, which means even if you pick a plan day one of open enrollment, the earliest that plan is going to start is January 1st. So it is important to figure out that you have your coverage maintained all the way through December. If you want a Marketplace plan to start January 1st, you have to make sure you enroll before December 15th. So just keep that piece in mind as well. So how do you enroll? Well, both for Medicaid and Marketplace, you can start at healthcare.gov. There's also a Spanish version. Some states run their own state marketplaces. But if you start at healthcare.gov, the very first question is, what state do you live in? And then it will automatically send you to the right place. So I think that's sort of, if you're going to remember one thing, that's the thing. But you don't have to be online. Some people aren't comfortable online. There's a phone number and a paper application. There's also in-person assisters. So you can actually like sit down and talk with somebody about your various options. And I've given you the link here on how you can find those people. And all of this information is included in our quick guide to the marketplaces on triagecancer.org. But the good news is, both with Marketplace and with Medicare, the law recognizes that things don't just change during open enrollment. So both programs have special enrollment periods. They're slightly different. For the Marketplace, if you have a situation where you're losing coverage, or you have a life-changing event, like you're changing where you live, or the makeup of your household changes, it would trigger a special enrollment where someone would have 60 days to pick up a new plan through the health insurance marketplaces. So what that means, really fantastic news, frankly, for all of us as consumers, is that if someone is going to lose their employer-sponsored health insurance, and this could be the employee, it could be the employee's spouse, it could be the employee's child that's on that insurance. If something is happening that's going to result in them losing that coverage through the employer, they actually have more options than they've ever had in the past. So the first option is to elect COBRA or state COBRA, where they would keep the exact same health insurance. Lane 2 would be to pick up a new plan through their state health insurance marketplace and potentially access financial assistance to do so. Lane 3 would be to see if potentially there's another group plan that they could get on. So can they get on a spouse's plan, or if they're under the age of 26, could they get on a parent's plan? And finally, lane 4 would be potentially if, based on circumstances, maybe they're going to now be eligible for Medicaid or Medicare. But the trick with this is that you have to pick a lane and stay in it. You don't get to change lanes until the next open enrollment period. And where we see this practically happening is people are in the middle of treatment, they're stressed out, they're leaving their jobs, and they get handed COBRA paperwork and they think, this is the easiest, I'm just going to do it. And then they're 3 or 4 months in and they think, oh my goodness, this is so expensive, I can't maintain it. Can I go get a marketplace plan with some financial assistance? And the answer, unfortunately, is no. Not unless you have a new special enrollment period or it's open enrollment. So we really want people to make the right decision for them in that first 60-day period. Now, I know this is a lot of information, and so I just want to point out we have an animated video and a quick guide on this topic specifically about what to do when losing employer-sponsored insurance. So we have all these options. How do we actually make choices between these different options if the ultimate goal is to make sure that we can get the care that we need and minimize, to the extent possible, the out-of-pocket costs? I am going to give you an example using some marketplace plans, but this exact analysis that I'm about to walk you through can be used if you're trying to compare 2 marketplace plans, if you're trying to compare between 2 plans your employer is offering you, if you're trying to decide, well, do I take my employer plan or is a marketplace plan better for me? Because we aren't required to take our employer plans. Or if you're trying to decide between 2 Advantage plans, exact same analysis is going to work. So here we have 3 different plans. We have a bronze plan with a $173 monthly premium, a $6,000 out-of-pocket maximum, a silver plan with a $271 monthly premium and a $5,200 out-of-pocket maximum, and a platinum plan with almost $400 monthly premium and an $1,150 out-of-pocket maximum. So assuming I'm going to hit my out-of-pocket maximum, which when we're talking about a cancer diagnosis and active treatment is a fair assumption. Assuming I'm going to hit that, which plan is going to cost me the least by the end of the year? Can we just tell by looking at it? I can't. I actually have to do the math. And the way that you do the math is you take the monthly premium and you multiply it by 12, because that's how much you're going to pay in premiums for the year. And then you're going to add the out-of-pocket maximum. And when you do that for all 3 plans, you see here in this example, that platinum plan with a $400 a month monthly premium ends up being over $2,000 cheaper by the end of the year. Now, I'm going to be honest, we do this all over the country. It doesn't always turn out this way. Sometimes the bronze plan is the cheapest. But the point is, if we're trying to figure out how do we minimize out-of-pocket costs, we can't get sticker shock by only looking at that monthly premium. We have to do the math to figure out, well, what's it going to cost us for the entire year? But of course, that's only one piece of the puzzle. Also, looking at things like the deductible can be very helpful. So yes, that bronze plan you're only paying $173 a month, but it has a $6,000 deductible, which means you have to pay $6,000. You have to write a $6,000 check before the insurance company starts picking up anything. Whereas with the Platinum plan, yes, you're paying more each month, but it's picking up 90% right away. So for most of us, it's easier to pay a little bit more each month than it is to come up with a big thousands of dollar lump sum check. We also need to make sure that whatever plan we're settling on covers our doctors and providers and facilities, because having a affordable plan that doesn't have any of our providers in the network isn't actually going to end up being affordable. And that's because of what I talked about, that most plans will only count payments made towards in-network providers towards that out-of-pocket maximum. The same is true for your prescription drug coverage. So you want to make sure that any drugs you're currently taking and any drugs that you can foresee taking in the year coming are in that plan's formulary or their list of drugs that they cover. Some plans may also have a separate drug deductible. So looking at that can be very, very helpful. So I do see a question in the chat box about, in my example here, is this out-of-pocket maximum monthly? No, the out-of-pocket maximums, I've never seen a monthly out-of-pocket maximum. They're always annual for the year, and they're always that fixed dollar amount. All right, so I just said to you that you have to make sure that your providers and facilities are in network and the drugs are in the plan's formulary. So how do you do that? If you are shopping on the marketplace and you're using the website, the online tool, there's some options. You can actually put in your providers and your prescription drugs into the system, and it will help filter it out. I will admit to you, this is not a perfect fail-safe system. We definitely know that the online database isn't as up to date as we would like it to be. So step one is to put it into the system to see if your providers are listed, but we don't recommend you rely on that. You should also call the providers and ask them if they take that plan. I definitely don't recommend that you call and say, do you take Obamacare or do you take a marketplace plan? Because more often than not, the answer is no. But if you say, and I'm making this up, do you take Humana Gold 350 PPO? So that you know exactly what plan that you're talking about, and the provider can answer you in that question. Now, picking a plan is so important. Picking the right plan is so important to this whole conversation about minimizing out-of-pocket costs and access to care and financial stability, that we have some resources I want to highlight. We have an animated video that walks through that example that I just gave you. I think it's like a 6-minute video. We also just this month released our health insurance comparison worksheet that can be downloaded at this link here. And in this worksheet, you can actually take 2 plans and write in the information. And then there's that math problem that I gave you below. And I have a colleague on with us today, and she's going to drop a link to a resource document that has clickable links to all of the things that I've been talking about today. So you don't have to feel like you have to write these links down quickly. So good news, we now have some tools under our belt, hopefully, to be able to pick the most appropriate plan available to us. Potential bad news is this is not a one-time chore. In fact, this is something that we have to do every single year. And the reason for that is sort of twofold. One, it could be that our options change. So maybe there's more financial assistance, maybe there's new plans being sold in your area. But many times our needs also change. So for people that call us and say, I'm drowning in bills, and we figure out the reason is they don't have the best plan for them, now we want them to pick a better plan for them for the year ahead. And that could be true for all of us. And then certainly if you are changing jobs, that's also an opportunity to be reviewing your options. The other potential bad news is getting the plan is only half the battle. then we have to make sure that we're making the most of that plan. So we're using in-network providers whenever possible so that they're being covered at as high of a rate as possible. You're asking for pre-authorizations when necessary and paying attention to bills. And we have lots and lots of resources on our website, both, sort of practical and legal, about how to deal with the medical bills that you might be getting. Certainly leveraging out-of-pocket maximums. So do you need any other care for the year? Could you get that this year so that you don't start over at zero? And then if you receive a claim denial, appeal it. As consumers, we generally have multiple levels or multiple opportunities to appeal a claim denial. The process or the steps is a little bit different in Medicare. And you'll see on that resources document, under cancer finances, we have an appeals module that walks you through the different steps based on what type of health insurance you have. But the problem here is that while millions of claims get denied in the United States every single year, a very small percentage of them ever get appealed. Yet we know that about half the time when somebody appeals a denied claim, they win. So roughly half the time when the insurance company is saying, nope, we're not going to cover that, and then someone goes through the appeals process, it turns out the insurance company was wrong. So when we talk about minimizing out-of-pocket costs, this appeals process is an incredibly important piece of the process, and it's wildly underutilized. Now, there's many reasons that it's underutilized. I think there's a knowledge issue. I think there's a capacity issue. So we're talking about people who are in the midst of a serious medical situation, and now we're saying, file an appeal and fight with your insurance company. But again, it's like, where can we start to help consumers of healthcare regain some of that control? And I think this is a good opportunity. So we have quite a few different resources to help make the appeals process potentially a little less awful. This is just a list of all of the different health insurance resources that we have at Triage Cancer. And again, you can find all of this on our website. We've organized the information in different ways. If you go to resources at the top and resources by topic, you'll see we have employment, disability insurance, estate planning, and health insurance. And that's where you're going to find most of the things that I've talked about today, also in that resources link. I briefly mentioned cancer finances, and I just want to talk to you about what it is so that you can use it in the future if it would be helpful for you. Cancer finances is a tool on our website that is built in a sort of choose your own adventure format. So you start by picking what topic you're interested in, let's say appeals, and then the system will ask you questions. And based on your answer to the questions, it will take you to only the relevant information. So if you tell me that you have Medicare, I'm not going to talk to you about appeals in the marketplace because that's not relevant to you. So it does, obviously take a device, but you can use it on a tablet or a smartphone, or of course a desktop as well. So I see some questions popping up. Happy to take questions for our remaining 10 minutes. But before I do, I want to just mention a couple of things. So if you're interested in continuing to learn, we certainly would love to see you at our educational events. ThyCa is a great partner at most of our events. We also have an educational blog, and that is where we do put some information about substantive topics, but it's also where we share late breaking news. As I'm sure you can imagine, when we're talking about health insurance and Medicare and Medicaid, there's lots of late breaking news. We also know that it's hard to remember to go back and check frequently. So we have a subscribe feature now where you can actually get, every time we post a new blog, it'll just come to your inbox. If you're on social media, we'd love for you to connect there. And then we also know that we can create all the resources in the world, but sometimes you just need a human to speak to get an answer to your question. So this year, we formally launched our legal and financial navigation program. This is a program where you can fill out a form on our website, and schedule a phone call with one of our staff. On that phone call, we can provide you with answers to your questions around these legal and practical issues. We do not provide legal advice. We do not provide legal representation. But what we do really try very hard to do is to give you answers, explain your options, give you potential next steps, or at the very least, point you in the right direction of who can give you the help that you need. So I'm going to leave this screen up so that if anyone wants to write down the link to our intake form, you can do so. And I'm going to just pop over to the Q&A box. Okay. If going to a new employer, are 3-month delays in health coverage beginning active still legal? Yes. So it is very common for employers to impose a waiting period for new employees before their benefits kick in. The Affordable Care Act limited those waiting periods to 90 days. So that's the ceiling of how long a waiting period can be. They could be shorter. So if somebody's in a situation where they're going from one job to another job, but job B the insurance benefits don't kick in for 90 days, they want to make sure they've done something to bridge the gap. And one option could be electing COBRA for just the 3 months until the new employer's benefits kick in. Can you talk about Part D and the out-of-pocket maximums in the donut hole? I sure can. So Part D, again, is the prescription drug coverage through Medicare. And Part D coverage is really kind of challenging because there is no out-of-pocket maximum. And the donut hole is something a lot of people have heard of, but don't necessarily understand. And the way that Part D coverage works is that first you have to pay your deductible, which for this year, the cap is, I think, $445. So $445 in a deductible. You pay that completely out of pocket. Then you enter what's called the initial coverage phase. During this time period, Medicare pays 75% of your prescription drug costs, and you're responsible for 25%. Then, after you've paid a certain amount out of pocket, you enter what's called the catastrophic coverage phase, where Medicare picks up 95% of your prescription drug costs, and you're responsible for either 5% or a nominal dollar figure, whichever is more. Unfortunately, in the cancer care context, that 5% is usually the thing that is more. And this is a serious practical challenge for Medicare recipients because 5% of a lot is going to be a lot. And there is no out-of-pocket maximum. And unfortunately, many people who were getting assistance through the pharmaceutical companies when they were on private insurance, like through an employer, can no longer get that financial assistance once they're in Medicare. So it is definitely a huge problem, and it's one without a ton of good answers. There are some financial assistance programs for Part D for individuals who have low incomes. It's referred to as extra help, or LIS, the low income subsidy. So given that there aren't really great answers, the one positive thing I want to leave you with is there's currently pending legislation to create an out-of-pocket maximum for Part D. And if you would like more information about that pending legislation, check out the advocacy page at triagecancer.org because we have some information there. And then if you care about this issue, definitely contact your elected officials and let them know why it's important for them to do this. So I hope that answered the Part D question. Yes, you can elect COBRA if you leave voluntarily. You can also elect COBRA if you've gone from, let's say, full-time to part-time, and your employer doesn't offer benefits to part-time employees. That would be a qualifying event to elect COBRA. There's a question about what's the charge for talking to a live person about insurance issues. If you are asking about our legal and financial navigation program, there is no charge. We are a nonprofit, so we provide these services to the community for free. But just as a reminder, we can't give legal advice or legal representation, but we can certainly talk about your various options and try to point you in the right direction. So there's a question about like who you would include in the household for the Affordable Care Act. And it's actually pretty complicated because it's pretty complicated. But when you are thinking about financial assistance, they do look at your entire household size and your entire household income to base that financial assistance, even if it's only one person in the household that needs the coverage through the ACA. So that answers the question. So for the individual who asked the question about moving from the marketplace HMO to Medicare, I'm actually going to ask you to fill out a form for our navigation program so that we can talk a little bit more, because I have a whole host of questions to ask you in response to your question. So because that's pretty specific to you, I think it'd be helpful for us to talk about that individually. So I hope you will take advantage of that. So there's a question about how do you get a medical exception to go to, I believe that's MD Anderson, if your individual plan will not let you go out of state, or an individual plan allows you to go to another state. It's tricky. To be perfectly honest, it's tricky. So if you have a plan that does not have out-of-network coverage and you're trying to go see a provider that's out of your network, you are responsible for 100%. The sort of exception to that rule is if you are trying to see a provider that doesn't exist in your plan's network. But I would definitely encourage you to get all the pre-authorizations before trying to do that, because that's really where we see a lot of people end up with huge bills, is, you know, they sort of think their coverage is gonna start and then it doesn't. But again, for that person, we'd be happy to talk more about specifics with you on the navigation program and see if maybe we can come up with some better answers.
Before the webinar cuts off, I just wanted to make sure to thank Monica so very much for your time today and answering all the questions and providing all of these resources. This has been so informative. I'm definitely going to go back and listen myself. And I think you have gotten, I just want to make sure we don't get cut off before I thank you. I think we've gotten to almost all of the questions, actually, pretty good in the Q&A.
Well, I just wanted to say thank you all so much for inviting me and for spending an hour on a Friday evening talking about health insurance.
Thank you so much.
Great rest of the conference.
Yep. Thanks, everyone.